Well, welcome everybody. Welcome to everybody here in the room and to those of you online. It looks like people are still coming in. So welcome. It's great for you all to be here. To kick off the start of our Dean's Lecture Series this year. And we're off to a great start with a fantastic speaker that I have the privilege of introducing you to. I always look forward to these lectures because they give us a chance to learn from our newly appointed and promoted professors here at the School of Public Health, as well as our senior scientists. We benefit from their experience, we hear their fresh ideas, and most importantly, we leave inspired by all that they're doing to change the world. And today, are people still coming into the Zoom room? Becky, should I hold off? They're all, okay, it's just moving pieces. All right, good. So today I am delighted to introduce Dr. Judith, or known as Judy Bass, a professor in the Department of Mental Health. And for those of you who may not know Judy all that well, she specializes in global mental health, a relatively young field, although Judy herself, not to give away her age or anything, but Judy herself has been involved in this growing field for over 20 years, and she helped define the field in many ways. Judy has dedicated her career to understanding what programs and interventions are most effective in different communities, as well as how to make those programs and interventions accessible to all people who are in need of them. This work is more urgent than ever before. It's estimated that there are nearly 1 billion, over 1 billion people worldwide living with a mental or behavioral health condition. Depression is a leading cause of disability across the globe. Suicide is the 4th leading cause of death among 15 to 29-year-olds. It's just staggering figures. People living with severe mental health conditions are at risk of dying prematurely, sometimes decades, many decades too soon. But as daunting as that may sound, there are effective treatments. And we know these treatments can be affordable. The gaps in access are great, but Judy will tell us through her that the research and the innovation, and very importantly, the local empowerment, through that, we can find ways to close these gaps. For decades, Judy has been working with trauma-affected populations in Uganda, Indonesia, Iraq, and other places around the world. One of her focus areas is task-sharing interventions. In other words, finding ways that people outside the traditional mental health workforce can be part of a positive change in their communities. So I would like to tell you just one story. One of the first projects that Judy led was in Kinshasa in the Democratic Republic of Congo. And this story is particularly fitting for today's lecture because this morning we hosted actually a very high delegation from DRC, including the Minister of Health. And they spoke about the declining life expectancy in the DRC, and really focused on one of the major contributing factors to that declining life expectancy around child and maternal and child mortality. So it was an interesting contrast listening to their talk this morning, and then listening to Judy today, who has worked in the DRC, but coming at the public health problems in DRC in a very different way around mental health. But Judy was brought in as a mental health expert in an HIV-related study looking at perinatal care. The team was based at a maternity hospital, which Judy tells us was run by a group of very strong Congolese nuns. Judy and her team worked with local women to conduct interviews on postpartum mental health. They found that when women were struggling, they didn't necessarily go to a nurse or to a clinic. They went to the respected mothers and grandmothers they knew. And often this was enough. They found the support they needed. And when Judy and her colleagues went to create a mental health program, they drew on the strengths of these practices, making these mothers and grandmothers part of a referral process. But they also took it a step further and developed avenues for women to find more formalized services to help them in more serious circumstances. When new mothers had symptoms of depression and anxiety that did not abate, when gender-based violence was a threat, those community mothers and grandmothers could help direct the women to other means of support that could help them and assist them. Judy will tell you that mental health does not sit in a silo. It's connected to poverty, to violence, to living in conflict zones. Her ongoing work is grounded in the principle that mental health should be integrated into other systems of healthcare. Whether she is working with Ukrainian veterans or refugees in Thailand, she's advancing our understanding of what works and what is most effective, and very importantly, what's most sustainable in a particular community. She is helping to create holistic solutions that can take root and make a lasting impact around the world, allowing us to work toward a future where no longer will we have to recite these statistics that I shared with you early on, that 1 billion people are suffering with a mental health problem. Now, Judy's impact comes not only through her research, but of course through her teaching and her mentoring, a role in which she truly, truly shines. She is her department's vice chair of education and currently leads an NIH funding training program in global mental health, which is focused on interdisciplinary research and teaching and mentoring. She's known for working incredibly hard for all of those around her. And I think that some of you in this room will attest to that for sure. I am also thrilled that Judy has taken on a role at the school. She herself identified the need for a director of PhD education for the school. You know, you realize that our PhD programs sit in departments, the 10 different departments across our school. And she saw the need to kind of thread those programs together, to bring the PhD programs together on a regular basis, to problem solve, but also to identify best practices. And she's done a wonderful job pulling this group together. And I can tell you, when you're around Judy, when I'm around Judy, I'm always struck by her enthusiasm for teaching. Her commitment to her students is palpable. If you ask her what they're working on, she immediately goes into, well, this person's doing that person's doing this, and she just revels in the success of her students. Now, one final note about Judy. When you ask her colleagues what's special about her, they will tell you that she models a commitment to work and to family. She has 2 children and parents who just moved to Baltimore, and we're thrilled to have her parents here with us today. Thank you for coming. She leads by example, balancing the busy life of a professor with the deep importance and commitment of time to family. She always looks for ways to help others do the same. Judy has said that, and I quote, "In mental health, the basis of empowerment is building strength." Judy, we are grateful to all you have done to build strength in others and nurture well-being here at our school and in communities around the world. We are so excited to hear from you today. Professor Bass.
Thank you. All right. Thank you, Dean McKenzie, for the kind words, and good afternoon to everyone in the room and on the Zoom. I want to start with a quote from my colleague, Paul Bolton, that acts as a guiding light of sorts for our work. No survey without service. That is, our choice of research activities are guided by the direct utility for improving mental health services for the populations we're working with. Before I begin, I want to share a bit about my circuitous pathway to this field, both because I feel it's helpful for students and trainees to know that there are many paths forward, but also to share a bit about how I came to this field. My bachelor's degree research focused on proposing a framework for public peace process between Israelis and Palestinians, one that I had hoped could be implemented concurrently with government peace, and one that I can still hope for. Then I worked for a few years in the early advocacy for electronic medical records. I guess we were successful there. I knew I wanted to get back to international work, so I began a master's in international affairs, and while taking a course in public health, I fell in love with epidemiology. I then spent 2 years working at the CDC as an Association of Schools of Public Health Fellow, doing surveys on pesticide use and lead poisoning up and down the US-Mexico border. I was continuing to keep my global interests central to my work. While at the CDC, I also supported water and sanitation survey response for 2 natural disasters, the big tornado in Oklahoma and a major hurricane in North Carolina. I was struck during these field activities by the mental health needs of the impacted populations and by the lack of services beyond the Red Cross providing supportive care. This led to more questions and a realization that if I wanted to dig into these issues in the US and globally, I would need more education, which led me to my PhD here in the Department of Mental Health. And a few months in, after knocking on lots of doors, to find anyone doing mental health internationally, I was introduced to Paul Bolton, who I started to work with then and continue to work with today. After I finished my PhD, Paul brought me up to BU as an assistant professor, but it didn't take long for me to convince the then chair, Dr. Bill Eaton, that the Bloomberg School needed a global mental health program. And so he brought me back as faculty in 2007. When I first came to Hopkins for my PhD, I learned that global mental health wasn't really much of a field yet in public health. It really was situated still in psychiatry. There was an existing tradition of cross-cultural or transcultural psychiatry with the big debate on the edic versus emic approaches. That is, some who argue that mental health is universal and some who argue that it's really locally embedded, when the truth is, it's somewhere in between. When I was starting my PhD, global mental health was just beginning to get attention as a public health issue. The 1996 Global Burden of Disease Study, which compares and contrasts the burden of different health conditions across the globe, identified mental disorders as 5 of the 10 leading causes of disability worldwide. This was followed by the first ever US Surgeon General's report on mental health, and then the Institute of Medicine's report on disorders in the developing world. And in 2001, the WHO's annual report focused on mental health for the very first time. And that year, World Health Day focused on mental health stigma. It was an exciting time to be coming into the field of global mental health, a time where I hope that my work could have a real impact. In terms of mental health problems and knowing where the gaps were, we weren't starting from scratch. There had been several cross-national and international surveys, including both the cross-national collaborative groups surveys, the ICPE surveys. However, it was really the World Mental Health Surveys, initiated by the WHO and now housed at Harvard, that provided initial data on variation in prevalence and, importantly, on gaps in treatment access around the world. The first paper, published in 2004, included middle and higher income countries, such as the US, France, Germany, Japan, and China, as well as lower income countries and emerging economies, such as Colombia, Mexico, Lebanon, Nigeria, and Ukraine. And while these presented a good place to start, there were some concerns given all these studies use standardized tools that weren't really adapted to the local context. So that situates where we started, where I came into this. And I mentioned in my background, when I first started my PhD, I found my way to Paul Bolton, a medical doctor who also had seen the lack of mental health services in his work with refugee camps over the years. When I first met him, he had just returned from Uganda, having completed a brief qualitative study with local staff from World Vision, who were concerned with the increasing rates of depression among adults living in villages highly impacted by the HIV epidemic. Conversations with local stakeholders, including ministers working in the community, found that while they identified depression-like problems, they reported that they didn't have the skills or program to help support people whose problems continued despite their basic supports. This led to the first trial of a talk therapy provided by local staff, in this case World Vision staff, in Africa. In discussions with our clinical psychology colleagues here in the US, We identified interpersonal psychotherapy, IPT, as an evidence-based intervention for depression that seemed worth trying. I'll note that when we talked to the developers of IPT and we said we wanted to do this, they said, okay, but we don't know if it's going to work. They were unsure because it hadn't been done yet. We worked in 30 villages, 15 randomized to receive the IPT groups, 15 as weight control, and groups were sex-specific with local World Vision staff trained as the providers and an international staff member providing the supervision. So what did we find? Our results were strong. At baseline, both groups had average depression severity scores of 23 on a scale from 0 to 45, so mid-range. And we had an algorithm where we approximated a DSM diagnosis of depression. And from that, about 86% of the sample would have met a diagnostic criteria for depression. So relatively high rates. At the analysis, we saw a mean reduction in symptoms of about 14 points. So remember, we started at 23, so 14 points is a big drop for the IPT participants, but only 2.7 for the controls, a significant difference. And when we looked at probable diagnosis, among the IPT participants, 31 still met our algorithm, only 22%. Well, 90 in the controls, 62% still met it. We also had the ability to go back 6 months later. So 6 months after the intervention was complete. This is now typically what is done, but back then this was new. And we followed them up. And what we also asked whether or not people continued to meet in their groups. And we found that the people who continued to meet in the groups without the intervention being implemented actually had sustained their mental health impacts. So this was starting to give us some early indications, not only of the benefit of the intervention, but the benefits of group processes, the social structures that we were building. So our trial first got published in the same year as the other first 2 trials of non-mental health professionals in low and middle income countries, one led by Ricardo Araya in Chile and one led by Vikram Patel in India. Together, these trials set the stage for a growing movement towards task sharing approaches, where providers with little or no mental health experience or treatment experience are trained in formal treatments and supervised by providers with more training. That is, together they share the responsibility of caring for the participants in the program. Over the next several years, task sharing interventions have been implemented with a range of different providers, peer providers, other community workers, clinical extension workers, other formal health system staff. This was also a time that our global mental health group, we named ourselves the Applied Mental Health Research Group because we had to come up with a name, was created. We started as a team of 4 faculty at Boston University with myself and Paul and Laura coming to Hopkins in 2007 and 2008. And we've continued to grow with now we have more than 20 plus faculty among our trainees and among our students at 5 different universities that we collaborate with. The strength in our numbers has allowed us to continue to grow in our depth as well as our breadth of mental health and psychosocial research and programming. It's very exciting. Our initial work and our continued work has been guided by that no survey without service principle. We work with local partners around the world to identify and develop measures to assess the mental health problems, to guide and select interventions, to monitor and evaluate them, and over time, we've now added providing support for the development of strategies to sustain them. Early on, we realized that we needed to have a basic but systematic approach to our work and collaborations, an approach that could easily be communicated and collaborated and implemented collaboratively. We refer to this as the DIME approach that supports the design, implementation, monitoring, and evaluation of interventions. This, as you can see, this approach starts with qualitative work. Qualitative work is the basis for all of our projects because we need to understand what are the relevant problems at that time in the words that are used by the local population we're working with. With funding from USAID, and after using and refining this approach, we developed a manual, basically a set of handbooks, for implementing this approach that can now be used by NGOs and other health researchers and is used around the world. So looking at the DIME approach, you can see that one of our starting places is that understanding what the problems are that are relevant to our local population. I have spent a good deal of my academic career focusing on measurement, and you'll see that throughout multiple slides that we talk about. And all of that starts with that qualitative work. So for example, the story that Dean McKenzie brought up at the beginning, our qualitative interviewing with local mothers in Congo identified a syndrome that they referred to as maladie souci, a syndrome of worry. They didn't call it depression. They didn't call it anxiety. They call it a syndrome of worry. It looks like depression and anxiety. That's fine. But we found the words and the terms and the idioms that were relevant there. And through that process, we were able to identify tools and adapt them to meet the local context. Measurement is key to accurate identification of problems and for evaluation, and continues to be a key issue as we move into implementation research and cross-population big data analyses. In the first decade, we completed more trial research. In northern Uganda, we did a follow-on from the first World Vision study where we replicated using IPT, and we were able to bring counselors that were trained from the first study up to be supervisors in the second study, thereby building local in-country capacity. And we also evaluated an intervention that was already being done there, a creative play intervention. And what we saw this was with adolescents, what we saw is that the IPT, it had an impact. Not surprising, because that's where we thought it would have the impact. But we also saw that the creative play intervention did not have an impact. So compared to controls, those adolescents participating in creative play did not see any more reductions in their symptoms. We worked in Indonesia. This is one of the first trials I actually led, was of a problem-solving therapy with war-affected adults in Aceh, Indonesia, with International Catholic Migration Commission. We evaluated their intervention. And similarly, we found that the intervention was not particularly effective. And not because it wasn't a good intervention, but it wasn't an intervention that was targeted towards the problems that were identified by the local population. So you can see we're starting to learn a theme. We learn what works and also what's not necessarily working. While researchers were expanding the evidence base for mental health treatments, the uptake of these programs was still limited. In 2007, Richard Horton, the editor of The Lancet, wrote an editorial highlighting the lack of impact of the WHO initial call to action in 2001, noting the limited action on the part to move the field forward in addressing mental health needs globally. As part of this series, they published this map of the availability of formally trained mental health staff, including psychiatrists, psychologists, social workers, which basically highlights that the resources are in the high-income countries. They noted resources for mental health treatment were inadequate, insufficient, and inequitably distributed. Following on this, in 2008, the WHO published the Mental Health Gap Action Program, or MHGAP. The guidelines were written as a general report with information justifying the need for mental health services because of their impacts on other priority health problems, not because of mental health specifically. That's changed. As well as general guidance for policy development and mobilization. They focused on 8 priority conditions: depression, schizophrenia, and other psychotic disorders, suicide, epilepsy, dementia, alcohol and illicit drug use disorders, and a catch-all category of disorders in childhood. Again, this has evolved with time. In 2010, they provided an implementation guide on how to use the MHGAP guidance, and predominantly focused in primary care settings. The intervention guide provides clinical decision-making algorithms healthcare workers can follow for cases of depression and the other disorders. And then, if they need to, it provides guidance on what pharmaceutical treatment to provide, as well as when to make referrals, with the expectation that they would do referral up to more severe cases, or referral out to psychosocial programs in the community. The challenge is there wasn't that much availability of referral up to psychiatrists, and there wasn't that much availability of established and scaled up psychosocial programs. And so the guidance provided a good starting place, but the referral systems were lacking at that time. So that's where we were at the end of the decade. And as we moved into the second decade, so now 2010-ish, there'd begin to be a shift in terms of interest from the larger health research funders, including the NIH. This was welcome news, as up until this point, research funding was predominantly from the NGOs themselves or USAID or other development agencies. In 2009, the NIMH created its first office focused on global mental health. Before this, most funding came through Fogarty. Pamela Collins, who had been at Columbia University, was recruited to lead this new center. And yes, we are lucky that now she's been recruited to lead our department. Under Pamela's leadership, NIMH initiated the global challenges, the grand challenges in global mental health with the Global Alliance for Chronic Disease in coordination with other funders such as Grand Challenges Canada. And while I'm focusing today's talk on the global mental health aspect, I do want to make sure you note that it wasn't just focused on international. There was a US focus included, particularly focused on underserved populations here. And with the NIH, other funders started to come on board, including the EU and the UK, Wellcome Trust, and ELRA, a funding agency that was started in 2009 to bridge the gap between academics and humanitarians in research. So the grand challenges set out 6 overarching goals for where research should be prioritized, with several summary principles guiding these priorities. These goals included identifying root causes and risk and protective factors, advancing prevention and implementation of early interventions, improving treatments and expanding access of care, raising awareness of global burden, building human resource capacity, and transforming health systems and policy. In previewing the presentation, I can say that as a field, and where our group has contributed, is we've made good progress on goal C, particularly improving treatments, D, raising awareness, and E, particularly building capacity at the community level. But there remain significant areas for growth in A, B, and F. So to advance the grand challenges, NIMH funded 5 regional collaborative hubs to extend research on interventions, particularly those integrated into existing care systems, such as primary care. These hubs included research as well as explicit activities focused on building more research and service capacity and involvement of end users in the research planning, including government, clinical, and service user viewpoints. Following on these 5 hubs, another later call came out to focus on research for scale up. I got to be a co-investigator on the Affirm hub and had the opportunity to work with colleagues in South Africa and Ethiopia on trials for perinatal depression and the use of health extension workers for providing ongoing pharmacological treatment for people with severe mental illness. I also co-led the shared research projects across the 5 hub, which has formed the basis of a project I'm actually working on today. So in the context of the research that NIH and other traditional research institutes were starting to fund, our group continued to be heavily supported by USAID to continue to help build the evidence for mental health services for conflict and torture affected populations, particularly those in humanitarian contexts, where research dollars for mental health was still quite limited. This is one of the studies that I led starting in 2010, and that was initiated in part because of the recognition that root causes of mental health problems are multifaceted. In this case, both poverty as well as gender-based violence. We began working with the IRC, the International Rescue Committee, who had a substantial programming for women in Eastern DRC in 2007 that set the stage for this trial. The overall objective was to identify interventions that could be scaled and sustained. And through funding from both USAID and the World Bank, we were able to complete 2 trials, one on a mental health intervention and one on a socioeconomic intervention. The mental health intervention that we selected was called cognitive processing therapy. And we picked this intervention because it was originally developed and had strong evidence for the mental health problems related to women who had experienced rape and sexual violence. So it was a good fit for where we were. The social economic intervention that we selected was called the Village Savings and Loans Associations, which was at the times a social economic program that was being scaled up in multiple countries in Africa. And that basically is groups of 20 to 25 women who come together, share resources, share money on a monthly or weekly basis, and then give out loans to one another and pay back with a limited interest with the goal of creating economic stability, and they get a payout annually. So you're sort of creating a system of shared economics internally. These were two of the very first trials to be conducted in a context of ongoing conflict and violence. Most studies had waited until the conflict was over or until the population was in a more stable location, like a refugee camp. However, given the protracted nature of violence in the DRC, if we had waited, then these women might still never have received the services that they need. So what we found, working with IRC and the local community, is that through the CPT intervention, we had a reduction in mental health symptoms, both anxiety and depression, post-traumatic stress, and we saw impacts on daily functioning. So these are 1 month and 6 months after the intervention. With support from USAID, we actually got to go back 5 years after the intervention had complete. And we re-interviewed 103 out of the original 157 women in 5 of the villages, as well as 5 of the psychosocial counselors that were there. And what we saw was that a large proportion of them maintained their low symptoms. The intervention, without any more programming going on, this intervention, the women who went through it, many of them remained with low symptoms. Not all of them. That's the reality. Many of them remained with low symptoms. But what we learned was that many of the women also continued to meet with their group. Remember, this gets back to that conversation we had, what I mentioned with the Uganda study. There is power in groups. So when group interventions are possible, there's a potential for that support system to continue. When we asked them what they did in their groups, many of them talked about still using the skills they learned in the CPT. So giving us some nuggets that the intervention was not just helping reduce their symptoms in the moment, but maybe they were learning the skills to continue, because goodness knows they were still experiencing the traumas over the course of that 5 years. So you can see from some of these quotes that they really valued the intervention that they learned about, and that they valued the providers who were still in their communities, despite the fact that the intervention program was no longer an implemented program. As I said, we also did that economic trial, and we looked and we saw that there were some economic impacts, which is what we would have expected. There was improvements in average food consumption, some numbers of animals owned, and these are some of the early indicators that you would see with economic interventions. Nothing giant, it's a small program, but starting to see that. But when we looked at the mental health outcomes, we didn't see much. So again, giving us a hint that if all you do is an intervention for one piece of a problem, that maybe that's not sufficient. It wasn't just sufficient to start to address the economic programs. We had to think about economic programs with mental health interventions if we're going to be addressing the mental health burden. So one key thing that we kept noticing in our collaborations and research was that while most intervention programs were typically focused on a single disorder, the depression interventions, the anxiety depression interventions, post-traumatic stress research, most of the people participating in the programs experienced multiple mental and behavioral health problems. For all of you students who are in the Department of Mental Health, comorbidity is common. In fact, comorbidity is probably more common than just having a single disorder. This led our clinical team, led by Laura Murray, and her colleague Shannon Dorsey from the University of Washington, to develop a new treatment approach, the Common Elements Treatment Approach. This transdiagnostic approach is one that could be flexible so that this one program could provide treatment for a range of different combinations and a range of different presentations. And through USAID funding, we completed multiple trials of conflict-affected populations, evaluating the impact of CEDA. And what we saw was that over and over, the intervention could have an impact on multiple outcomes, and it was acceptable. Most recently, before COVID and the Russian invasion in Ukraine, we completed a trial of full CEDA, which is typically 8 to 12 sessions, and a briefer 5-session version, and found that while both were effective, comparison to a weight-controlled petition, the full CEDA, not surprisingly, was more effective, but the brief CEDA still had an impact. And this was really invaluable as we have continued to support our trainers and providers in Ukraine to continue to give the briefer versions of CEDA, which is necessary given the contextual and time constraints that they now face. In addition to the research on trauma-affected populations, I've also worked in other areas of mental health, so not just the trauma world. I built on our early Uganda work with HIV-affected adults with a caregiver study to improve neurodevelopmental outcomes among HIV-affected children in Uganda with colleagues from Makerere University, Bar Ilan University in Israel, and Michael Boyven and Michigan State University. In addition to looking at the child outcomes, we looked at the mental health of the caregivers. In the trial, we found that the caregivers in both the treatment condition and the control condition experienced improvement in their mental health. And so basically the supportive care for parenting started to have some improvements. And so starting to look at, our other interventions didn't have an improvement in mental health, just looking at economics, but looking at caregivers who are in highly stressed areas did start to have an impact on their mental health without having to do a mental health specific intervention. More data to help develop more hypotheses. In addition to the intervention work, as I've said, I spend a lot of my time thinking about measurement. We realized early on that many of the mental health tools, including the depression screeners, were developed in contexts and with populations quite different from what we see in many low and middle income countries, which can result in inaccurate measurement. This is one of the reasons we implement the DIME process, to make sure we're getting things correct. Enough data now existed to begin to explore whether a standard tool could be created. So led by one of our doctoral students, who is now a faculty, Associate Professor Emily Harose, she reviewed the global literature on depression and used item response theory to create the International Depression Symptom Scale, which has a core set of symptoms that can be used globally with the addition of local symptoms added on. And we typically use this in most of our studies. And similar to what we saw at the beginning of our research in global mental health, we began to recognize that as the field was moving more towards scale up and sustainability, measurement and tools to guide that work were similarly inadequate and generally not appropriate for the contexts. So we began the process of developing and adapting existing tools for scale up of mental health interventions. So what was the state of intervention evidence and research in low and middle income countries as we came at the close of the 2020s, at the close of that decade? In just looking at that literature, so remember where we were at sort of 2010, in just looking at that literature, there are now sufficient trials to populate more than a dozen systematic reviews in 2019 and 2020 alone. And most of the research was on general populations, for common mental health problems, some targeted research on HIV, people in the perinatal period, violence-affected populations, humanitarian contexts. But most of the research was adult-focused, with some emerging research on adolescence, but very little on aging. These studies continued to grow the evidence base for brief psychosocial as well as multi-session therapies provided in groups and individually and delivered in communities and clinic-based. And an umbrella review, which is a review of reviews, found that most of the research evidence provided support for the cognitive behavioral therapies and interpersonal therapies. An important note, though, that the authors made from the umbrella review was that there was really sufficient evidence now. And basically, they wanted to make the argument that, quote, the generic view that evidence is absent in poor research settings is wrong. There is now sufficient evidence to begin to move forward to scale up. So at this point in the evolution of global mental health intervention, we really knew that interventions could be implemented, but the mental health problems were still growing. We were not seeing the impact of these interventions. Why? Part of it was that the sustained funding remained limited for implementing these after the studies, but part of it was also that we weren't addressing the social drivers, the social determinants of many of these problems, including stigma, poverty, violence, and marginalization. So at the end of the decade, two important initiatives came out: the 2018 Lancet Commission on Global Mental Health and the UN Sustainable Development Goals. These initiatives sought to push the field forward more rapidly by framing mental health as a global public health good. Remember I said that mental health was considered important because it had an impact on on other health conditions. Now it's a recognition that mental health is an important public health problem because mental health is a public good. They acknowledge that mental health problems exist along a continuum. They emphasize that mental health of an individual is influenced by both biological and social and environmental factors. And they advocated for mental health as a fundamental human right, which required systems and services to utilize rights-based approaches. Building off these calls, in 2019, the WHO announced their newest initiative for mental health with a focus on universal health coverage and equity and human rights. The goal was to expand access and build mental health policies and systems of care in 12 countries. And while the COVID-19 pandemic and war in Ukraine have slowed things down, the initiative is ongoing with 9 countries currently on board, moving from the planning and design phase to implementation. So we can't move to where we are now without acknowledging what's happened these last few years. COVID-19 brought global attention to mental health, including the heavy focus on healthcare and frontline workers. And it has spurred rapid innovation in electronic and mHealth delivered interventions. And we're still learning about their impacts and potential. The war in Ukraine resulted in a massive refugee and displaced population surge in Europe without adequate mental health planning, but it also spotlighted the lack of focus on the other war-related refugee and displaced populations from Africa and the Middle East. Climate change, the heat, the hurricanes, the floods have impacted us all, but has mostly impacted disproportionately vulnerable populations around the world. And the social unrest and racial reckoning that is happening here in the US and globally has brought attention to historically marginalized populations, like African Americans here in the US, requiring us to address the issues of structural racism and systemic marginalization and violence, and in the realm of global health, a real call to action to address the power imbalances that exist in our research and practice agendas between the global North and the global South. These factors provide the backdrop for my current work. So now I'm going to give a little snapshot of our current projects. So as I mentioned, that Collaborative Hubs project, where I was the lead of the shared project, formed the basis of some work I'm doing now. So building off of that, with now new NIMH funding, we recognized that as task sharing was being scaled up, there weren't tools to help identify what are the barriers and facilitators to scaling up task sharing in a systematic way that could provide places for interventions when there was problems, when it wasn't working, when there was bumps in the road. And so together with colleagues from Nepal, from Chile, and from South Africa, myself and my co-PI, Larry Yang from NYU, have been working on validating and assessing the psychometric properties of this tool. And what's been really exciting about it is that we're actually doing it concurrently in all 3 countries. So we're not doing it in one and then learning in the next. We're actually doing concurrent research, which is bang your head on the wall hard and frustrating and slow, but also means that we're moving things forward in a way that truly should hit global importance rather than individual country importance. Unless you think that task sharing tools might only be useful in the international sector, task sharing is is an initiative that is growing here in the US as well. And we have a couple of the researchers from the US-based work who are part of our advisory board for the grant so that the tool could be useful here in the US. To address the need to consider mental health on a continuum, we have been working with JPIGO, a US-based NGO here at Hopkins for people who don't know, with funding from USAID to implement a multi-level program for people in the perinatal period, so before they give birth through several years after, in Myanmar, a context of ongoing conflict. When we started working in Myanmar, it was in a period of safety and security, and now since the coup in 2000, it has been a place of insecurity. In this model, we have community-based volunteers and clinical extension workers delivering simple psychoeducation using handouts and conversation points. And then if they identify someone who needs more, they have a referral. They refer them to a local psychosocial counselor. These psychosocial counselors provide more specific skills in stress reduction and thinking in a different way, and then screen for safety and provide safety protocols, safety referrals for people who are at risk of suicidality or violence, and they can provide those referrals to other organizations or up the ladder to more mental health services. And then at the top level, we have mental health counselors, again, who are Burmese because we've been working there so long. We have Burmese trainers in CETA. So our Burmese trainers have trained Burmese providers in CETA and all the way down the trajectory to treat people with moderate to severe mental health problems. At each of these levels, we establish that supervision system so that we have the task sharing, not just the task shifting, and we make sure that it is all sustained in terms of working to making this embedded within the system. To move the field forward on mental health services integrated into existing care systems, we are working with the IRC and with the Thai Konkan University on an ELRA-funded study. So this is a study to look at, can CETA be used to improve to medication adherence among people living with diabetes and cardiovascular disease in the refugee camp in Thailand. And what's important here is that medication adherence is hard. It's hard in any context. But when you're working in a humanitarian context, medication adherence is even more complicated. And we have higher rates of poor adherence. So can we address this poor adherence by implementing a mental health intervention? And what we found, we've completed baseline 224 people enrolled in the trial. And about 50% of them showed really elevated rates of depression, post-traumatic stress, alcohol, or chat use. So we were able, by doing a cardiovascular and diabetes study, capture people with mental health problems and give them the same intervention, the CETA intervention, to address the maintenance, the pharmaceutical maintenance, their treatment, as well as their mental health problems. So we'll see in the next 6 months how effective it was. This is a hard slide to look at, so don't look at the details. It's just the picture I'm asking you to look at. We also recognize that we need to move things forward to better understand social and structural determinants. In this realm, I'm working with colleagues from the engineering department, led by Taki Gusa, on a few projects that utilize systems dynamics modeling approaches. One project that was funded by USAID and is in collaboration again with World Vision in Honduras and El Salvador is being designed to better understand factors associated with different types of community violence against children. The second project, funded by a Hopkins Discovery Award, is designed to understand the intersecting links between climate change, conflict, and mental health in Mali. This project is led by my colleague, Yura Agustinovicius, a former student who is now faculty at McGill. Both of these projects began with collaborative in-country work, with that qualitative work with stakeholders to design the models, and we're continuing to go back, once we build the models, to go back and talk with them and make sure these models are correct. In fact, just last week, I got to zoom in to a half-day meeting in Mali, starting at 5:30 in the morning, as they presented this, as our Mali colleagues presented this model and got feedback from a whole new set of experts, Mali environmental workers, medical workers, and conflict experts, to continue to build this model as we move into the data collection phase. The intention of both of these projects is to better model the nonlinear and complex relationships between different structural factors and social factors, with the goal of identifying targets for prevention interventions. And finally, recognizing that there is potential to bring global learnings here to Baltimore, I received funding through the Bloomberg American Health Initiative, the BAHI program, to explore whether a chatbot that was originally developed by the WHO could be acceptable and useful for youth here in Baltimore. For this project, we worked with the Center for Adolescent Health Youth Advisory Board to design and guide the full study program and implementation. And we learned that whilst adolescents are using a lot of social media and a lot of technology, they didn't really want a technology AI-based tool for mental health and support. They wanted to talk to people. They wanted services that they could go to in person. This year, there have been several publications seeking to define where the field of global mental health is today. Our commentaries have many similarities as to where we've gotten to and strong ideas for where we could go or should go next. I am currently the co-editor-in-chief of the Cambridge Prism's Global Mental Health Journal, and together with my co-editor-in-chief, Dixon Chibanda from Zimbabwe, and our associate editors, Inga Peterson from South Africa, Marit Siljebrand from the Netherlands, Peter Winkler from the Czech Republic, and Rahul Shidaye from India, we shared our vision for global mental health research going forward. And I want to highlight that we situate our perspective in a public mental health approach, incorporating culture and context and prioritizing equity and inclusion, particularly of previously marginalized groups. We prioritize and emphasize knowledge generation, which is relevant, transferable, and generalizable to different populations and settings. So this leads me to my final part as to where I hope and where I think global mental health research could go next. What do we need to do? We need to prioritize system-based approaches so that we're integrating mental health and psychosocial programming into systems of care, rather than continuing to focus on individual interventions or programs, a real multi-level, multi-system approach. We need to build evidence for prevention and promotion, which means having a strong focus on social and structural determinants. My colleague, Sarah Murray, from our group is leading work on stigma and stigma interventions in this area. We need to refine and actually increase collaborative approaches for service intervention implementation. This means including users, providers, system administrators, and policymakers from the beginning. Just like the NIMH original hubs required that they bring people in from the beginning, all of our projects need to include these populations from the beginning. I hope that we could establish more opportunities for collaborative research. I have this nugget of a dream where we create sharing opportunities for sharing research in real time, whether it's measurement research or intervention research or implementation strategy research, that we have these opportunities for sharing in real time so that any one project, any one study doesn't hold the power. Any one research team doesn't hold the power, but it's the power of everybody's projects coming together and sharing what's working and what's not working in real time. Opportunity to raise up the influence of our collaborators around the world. And in all of these activities, we need to increase and value diverse voices and experiences. Too often, diversity is included in advisory roles, but we need to be more intentional and active in including research and community members with lived experience, with leadership from the countries and contexts where the research and programming is being implemented. So with that, I gotta say my thank yous. Too many people to thank, but it's have to start with my parents who are here and my family. It is, many people have already gotten a chance to meet them, but that is my Dr. J. Bass Sr. I get to be the Dr. J. Bass Jr. And showing me the model of what it means to be a professor and focusing on, that it's the work. I would rather people know the work before they know my name. My global mental health colleagues, including the many students who have become colleagues who I still have the benefit and joy to work with. The Department of Mental Health faculty and staff, with special shout out to our grants management staff who, have to work with all these international folks and international projects, and they do it with grace and with kindness. The Center for Humanitarian Health colleagues, our School of Public Health friends and colleagues, because I did my PhD here, many of them were students with me. It's a fun place to be. And our growing collaborative agencies from around the world. So my colleagues, both from US institutions as well as international institutions. Thank you for supporting me, for supporting our global mental health work, and for meeting the mental health needs of populations around the world.
Well, Dr. J. Bass, the Dr. J. Bass, that was absolutely fantastic. What an incredibly cogent overview of the field of global mental health and the contributions you've made along the way. It's just fantastic. I'm sure there are lots of questions and comments, but let me take the prerogative of asking you one. with these task sharing programs and CPT programs, is it CPT? I'm used to
There's
CBT,
CPT, CBT,
yeah,
IPT,
yeah.
there's lots of them.
What issues have you seen around uptake? Not uptake by
Yeah.
organizations, but uptake by individuals. And clearly stigma plays a role. But
Yeah.
that seems to me a real challenge of getting people to use these and to engage in these interventions.
So part of our initial qualitative work is to understand the words and terminology that people use to communicate their mental health distress. And so when we develop programs and implement programs, we don't say we're doing a depression program. We say we're doing a program to address maladie à souci. We're doing a program that addresses the functional impairments or the challenges that you yourselves have told us about. When we use the words and the terminology that the population have told us how they talk about mental health, we don't really have a problem with uptake. You know, the uptake challenges are people feel like you'll always have the early adopters and the people who feel more confident, but we're getting referrals. So even in Myanmar, we just had a call the other day where they said, oh, we're not just getting referrals from our focal points. We're now getting referrals from people who went through the program, who are referring it to their neighbor, to their community members. And so that's a real importance of thinking about where should it be? Where should it be situated? So asking people, do we put it in the clinic? Do we put it in the church? Do we put it in the school? Where should we put this intervention? And what should we call it? Is really guided by the group we're working with. And so I don't think we really have that much difficulty with uptake from the population when we take those steps. I think the biggest challenge with one of the big challenges with sustainability is making sure that the systems are in place to provide the supervision and the support so that the program can be maintained.
Questions, and if you have a question online, just what should we?
Raise the Zoom hand.
Well, we can't see their Zoom hands here, though.
I can
Yeah. There's a.
I'll get some congratulations.
Yes.
But Pamela, why don't we turn to Pamela? Yeah.
Yeah.
Sure. Oh, yeah. Press the button. Is there a green light?
First of all, that was a fabulous talk, Judy. Congratulations. Really, really, really wonderful. I was struck by what you found in all of your group interventions, the durability of the relationships of people that have gone through these interventions. And it made me think about what can be done to promote that sort of relationship more generally in communities. There's a big move right now in the US to bring integrative community therapy, which originated in Brazil and brings community members together who don't have a diagnosis of a mental health problem, but can bring problems and get a community of people to solve the problem with them. So it's a group intervention that supports people, and I'm wondering if you've thought about. So that's one, that's one example for people that don't have a diagnosis. But you're talking about people who do have a diagnosis, but still, it's about bringing this sustained, safe place. What thoughts do you have about how we might do that more broadly?
So when it comes to group intervention, so the experience of people who've gone through the group intervention, I think for anybody who's gone through a group process, an intensive group process, you create a bond. I mean, you've gone through a therapeutic program, sort of like the cohort of doctoral students going through your comprehensive exams. You go through the process together, and there's something about that bond, that creative support, that I think has been enduring. So when we have the opportunity to do group interventions, it is a really powerful tool. We don't always have the opportunity to do groups because in some places it's just too logistically hard. When it comes to non-intervention group type opportunities, I think there's a lot of potential. I would want there to be a facilitator, someone to help think about how to make it not devolve into sharing of problems or setting guidelines around confidentiality and what it means to be a group. So I think that's sort of part of what happens in the group process. A lot of the group therapy is not about the therapeutic part. It's about sort of building that comfort, that safety. And so I could imagine that group programs could have that when there are guardrails, when there are systems put in place to make sure there's safety, particularly when people are talking about hard issues or people who have shared experiences like violence, like substance use, like stigma and severe mental illness, that I would want to see some of those guardrails set up. But I think there could be a lot of potential in that.
Yes, go ahead.
First of all, thank you so much for the great talk. In line with the first question about, the language that people use to talk about various kind of ailments or disorders that they may have, I'm curious as to your process by which you do those initial qualitative interviews to assess kind of that foundational understanding.
Take my class second term.
No, I plan on doing that. But even just like a brief
Sure.
synopsis of
Absolutely.
how you
So we
approach
have a rapid assessment process. It's if you have enough people, you can do it all in 2 weeks. And it starts with some very general qualitative interview questions like, what are the problems of people in this community? We don't ask about mental health problems. We don't define what mental health is. People might define that word very differently. So what are the problems? And generally bubbling up in those problem lists are things that we hook onto are probable mental health problems. We pick 2 or 3 of those and we go in deeper. Someone told us about this problem of worry. Can you tell us more? So then we move to our key informants and we really dig in and we ask, who are the key informants? So in the Congo one, we talked to the local mamas. They gave us more and we build it deeper. And then we do member checking. We go back and we say, does this make sense? Sometimes we had to add new methods, but basically it's an iterative process where we start with very general questions and then dig in based on data coming up. So a ground up approach. Because if you use the term, what are the mental health problems? It used to be that we would get epilepsy and psychosis. Now we'll get what they think that we want to hear, which may not be what's actually relevant.
Was that a question that came in? If anybody online has a question, just type in the chat if you'd like to ask a question. We're monitoring the chat. Any other questions from the audience? Yes. Oh, here. Got to play my Vanya role. Sure.
Hello, I really enjoyed this lecture. I'm a pharmacist and I did a brief stint with a community-based project that was focused on mental health and psychosocial support back home in Cameroon in a humanitarian setting. And I think your lecture kind of puts in place certain things for me. Firstly, what you said about letting the community define what the problem is. And sometimes that can be a huge gap. This project used the IPT training with community health workers, and they kind of did it a step further, which was great, by training psychiatric nurses to be the referral pathway and creating a partnership with like a local hospital. So they did that well. But this is not really a question. It's just a remark on the experiences on the field and seeing how having knowledge like the work that you do could help improve some of these really needed services, but which are not getting the impact that they could get. So thank you for the work that you're doing.
Thank you.
And maybe see you in second term.
Yes. Get my exercise this way, right?
You might need to stand up, Tina.
Oh.
Oh wait, this one.
I got a little mic. Yeah, great presentation all around. Definitely reinforces my knowledge around global mental health. And so my question is around basically, so we know there's a need for multi-sector and structural interventions like you shown here with your the economic intervention integrated with the mental health one. So what are your thoughts on how can we get more sectors involved? Because we know it's not just the silo of mental health. There's so many more structural barriers and higher level things that trickle down. So I'm just curious to hear how do we get more people involved in what is a multi-sectoral issue?
Great question. And I am going to rely on all of you who are coming up in your PhD programs to be the ones to actually make it happen. Advocacy. I mean, I think this is where we need our voices, where we need to have evidence to say it's not enough just to do one, how integrated programs, structural programs can actually benefit all sectors, bringing in the economics, bringing in the World Bank. I think advocacy, a pillar of our school and a pillar of our program, is really about bringing to bear the evidence of what a mental health program could bring, not just to the mental health and centering the needs of the mental health needs, but also expanding to how it can be integrated and how it can be successfully impacting other outcomes in other programs. Hopefully we have some big advocacy folks coming on board with Paul Bolton and with Pamela's leadership.
And go ahead.
It's off.
Gone over that a couple times. But I was curious as to if you've seen any successful models for garnering funding within the countries you're working with, as opposed to from some of these more global agencies, potentially based in Europe and the West.
So such an important question. And I think it is in probably some of the more middle-income countries. I mean, I didn't present, but I've done some work in Brazil, some of the work in South Africa, some of the work in Chile is being supported internally. It's a hard one. I would say predominantly because so much of my work is in humanitarian contexts, that is, the funding is limited from in-country because those systems aren't really in place. But I think it's growing. There are regional efforts, particularly in parts of Africa, Central Africa, more so in Southern Africa. But I think those are where the partnerships with ministries and ministries identifying funds really come into play.
I have a question.
Sure.
Hi, thank you so much. So your talk was like, I was connecting it with our department mental health talk today at 12, where Baltimore City's like Healing Baltimore came and was talking about the work that they're doing to disseminate trauma-informed care. And that is so great. And it's so interesting as a model city. But one of the things that I was thinking about, or one of the things that you kind of mentioned towards like where we're going, is like the structural, like the next steps around the structural and like social transformation. So I think about so much of like trauma and like mental distress that we experience, especially in like war and with racism. There's so much of that like structural drivers and like risk factors that we haven't really like reconciled with. So like what do interventions look like in terms of like reparations or like reconciliation or like circle processes and things that we have seen with like apartheid ending and stuff. Like I don't hear that as much in these discussions, and I would love to hear more of that.
There's great research on those. And so the limited experience I have, so I worked in Indonesia and worked post some of the reconciliation processes in Aceh. In East Timor, in Timor-Leste. So we were working in Timor-Leste. And one of the things they talked about was that there had been reconciliation programs, that there had been community healing programs, that the government had done that. And that had produced a lot of healing. But there were people who were still struggling. And they felt that they couldn't struggle anymore. And they couldn't tell anyone they were struggling because the reconciliation processes had happened. And they were supposed to be okay. And so I think there's this tension to think about the structural system, so like those reconciliation, which is great, and that should be done. And it shouldn't be in replacement for thinking about what the individual people might also need. And so I think there is evidence that some of the reconciliation programs can have a community-wide impact, and for many people, a healing impact. And there needs to be interventions for individuals for whom that is not sufficient, for whom the trauma needs generates a need for more actual intervention.
We have a question up here, and then we'll go to Billy.
I'm scared for Bills.
All right. Thank you so much for the excellent, amazing lecture. Thank you so much. I enjoyed so much. I'm a faculty member, assistant scientist in the GDEC program in the Department of International Health. And I work in the area of task sharing with community health workers, particularly for the cardiovascular disease area of NCDs. And I always was looking for any chance to learn other experience about task sharing with community health workers, because that's such a niche area for sure. So my experience so far with working in this area is that it's really hard to make some knowledge which can be applied in other settings, which is particularly because community health workers are so different by each countries, and the systems values they're experiencing is very different either as well. And sometimes I have some dream of some, network where there's older researchers in the area and then share the experience, like, oh, my experience with doing this trial with this community health worker was like that, and then in this other country, the experience like that. So maybe there's something we can generalize and then make it, in some like a global agenda or something. And then that's been my struggle, or that's been what that stacks me for a little while. So I'm wondering how you have been generated this knowledge and then combine all the dots from all the trials you put so that it's gonna be, go up a little higher and then become a global agenda.
Oh, such a good question, and such an important question. I don't have an answer, but such an important question. And I think understanding, I'm hopeful that the BFITS tool will have some piece of that and understanding what barriers and facilitators work for task sharing that could be established for other health conditions. It doesn't have to be just for mental health. We're still validating it, but it could be a tool that could be used as programs are, the goal is to have a tool that could be used as programs are being rolled out to identify where things are working and where they aren't. And it doesn't, that tool could be adapted. So I'm hopeful. We're just in the psychometric evaluation stages. But I think that to meet the treatment gaps all around the world for many health conditions, we have to think about task sharing. We have to move things out of just the professional world into roles that are paid for and sustained. So they're not volunteers, but thinking about how to make things work so that we're actually getting people where they are in the communities and extending our programs. But we should continue that conversation. All right, Bill.
Bill.
I'm ready. Bill was my advisor, so.
Yeah, listen, that was inspiring. The talk was inspiring. Now I hope you don't roll your eyes too much when I begin this question, but the international research in psychiatry really, I think, began in the 60s, 50s and 60s and 70s with studies of schizophrenia and psychosis. But you haven't mentioned schizophrenia and psychosis at all in any of the work that you've done. So I'm just wondering how that fits in. Can you comment on it?
Great question. I think that is such an important question, and it is definitely a gap in our work, particularly in humanitarian contexts, where we have heavily focused on common mental disorders and not had an experience and not focused on severe mental illness. And I think that's a huge gap. That does not mean that's a huge gap for the field of global mental health generally. There are definitely people doing work on treatments and programs for people with severe mental illness. So I mentioned the AFFIRM trial that I got to collaborate on in Africa, and that was the Ethiopia trial was actually using community workers, so to be extension workers to help seeing if they could adequately support medication adherence for people with severe mental illness, so those people wouldn't have to get on the bus every month and face the stigma of going into the city.
Yeah.
So that research is doing, it is definitely, there's less of it. It is an area that there is extensive need, and it is a gap in our work in global mental health, but I know it's an important area. You trained me well.
You should be very proud, Bill. Okay, we have time for one more question. We have Gail Wallace online. And Gail, if you could unmute and ask your question.
Hi, good afternoon. Excellent presentation, Dr. Bass. This is one of the best presentations I've listened to, so thank you very much. My question is, I like your statement on systems of care that recognize structural and social determinants. How could a global research lens further advance bridging collaborative ties, let's say between the Congo, sorry, it's in small caps, between the Congo and Baltimore and Birmingham, looking at geriatric adult mental health around things such as comorbidities and cognitive aging health research. I'm just fascinated by this, global local connection because I too am very interested in qualitative research in local geriatric communities. So I'd be really interested to hear what advice you have. Thank you.
Thank you for that question. So that Baltimore project, that pilot project that I mentioned, the STARS project with the chat bot, we got the pilot money because we thought we were going to explore whether or not we could introduce it. The goal was to actually try to do concurrent research as the chatbot was being implemented in different parts of the world, including here in Baltimore. So to me, one of the potential ways, we didn't end up doing it in part because they said it wasn't going to be a useful intervention. But to me, one of the potential ways to think about these collaborative approaches is to actually do the research concurrently in the different countries. So Laura Murray has been leading a project they call the Zambama project. It's in Zambia and Alabama, concurrently looking at the CETA intervention. And I think these approaches where we are doing the work in the US, our colleagues are implementing the work in the other countries, and we are working collaboratively to understand what works, what structural factors differentiate, and what structural factors are the same as we work in these different contexts. So I think there are potential opportunities for concurrent research to really sort of dig into social structures and what might look like a social impact or a social factor, but may actually end up not being as relevant. Because that's a question, is how relevant for these different programs are the social constraints.
Thank you so much.
Well, thank you so very much, Judith. Again, just a terrific lecture. And you can see by all the questions, and I'm sure there are lots more, that people are really engaged. And I see more great work coming. And now with Pamela Collins, those of you who have not met Pamela Collins, is our new chair of the Department of Mental Health, who also has an interest in global mental health. So I just see this area just blossoming here at the School of Public Health, and it's so important. And you're doing fantastic work. So thank you so much for that, and continue on. And I want to thank all of you for attending here in person, but also all of those of you online. So please, those of you, so unfortunately the people online, you have to make your own reception, but those of you in the room, please join us out by the Wall of Wonder, and we can continue the conversation. Again, thanks for coming, and thank you, Dr. Bass.